which is the anesthetic session. And just let me just check, is Dr. Mulier has joined or not? I'm not sure of that. I can't see his name there.
Meanwhile, let me take this opportunity to thank Ahmed, Marcus, and Omar for this thought-provoking discussion, actually, I would say. I'm sure the whole audience, it will keep them thinking. Thank you.
Yeah, no, it was an interesting one. Dennis, is Dr. Mulier joined?
No, he's not joined. I can't see him in waiting room or anywhere.
So we could have continued with Omar then. Interesting. Shall we have a long break, Chetan, then? What shall we do? And perhaps we can start.
Yes.
Hi. Oh, we have the video. Why don't you play it then? Thank you. Yeah, fantastic.
Okay. Good. Yeah. Sanjay, you do that because I have.
Obviously, Dr. Mulier, I'm hoping he will join at the end of the video, but he has sent us a video. I'm sure he did not need any introduction. He's a consultant anesthetist in Bruges who works along with Dr. Delemans. He is probably the most published anesthetist for bariatrics in the world. And I met him 12 years ago, and I was so impressed by his skills in anesthetic and the way he turns around the patient in theaters. So I did request him to just share his tips for the surgeons, what we can learn from them and what they can learn from us. And let's see what he says to us. Thank you. And Dennis, please go ahead, please. And we have, I beg your pardon, we have Dr. George Vasilikostas and Mr. Koak, who is chairing the session, please. George, and yes, please go ahead.
Yes, hello everybody. It is my privilege to invite Dr. Mulier to present his presentation. I mean, there's no need for introduction. I was lucky enough to have my training in Belgium with Jacques Kimpens and Professor Kajer, and I was also lucky enough to visit myself in person their unit in Bruges. Work and the efficiency and the quality of the service that they present. So I'm aware about the time limitations. I don't want to waste the time, so please, let's start.
We can't hear it, Dennis.
Okay. Can you hear me, Sanjay?
We can hear you, but we can't hear the video.
Your anesthesiologist when doing a lot of bariatric anesthesia, and I would like to give you a lecture on what should you ask your anesthesiologist when performing bariatric surgery. What can your anesthesiologist do to help you improving the outcome of the surgical procedure? Let's go to here the next slide, and I set up my laser pointer. I have some potential conflicts of interest, but not related to this lecture. Well, I will start even with my conclusion slides. We will retake that at the end and discuss 10 points that are important when performing anesthesia, points that you can ask as a surgeon to your anesthesiologist. I will not go in detail on the specific anesthesia aspects, that's for the anesthesiologist, but aspects in which you can work together with your anesthesiologist in improving the outcome. And the first point is about the patient should never be laying flat. I will go very fast over the 10 points. It's about, well, ask to give not too much anesthesia, but just sufficiently, requiring monitoring. Avoid having still some air in the stomach on the moment you put the Ferris needle and start the insufflation for the pneumoperitoneum. Giving sufficient deep neuromuscular block by continuous infusion and monitoring is the only way to have full relaxation and to be able to work at the lowest pressure possible. Learn your anesthesiologist how to make an interpretation of the laparoscopic pictures and views so he can handle the gastric tube positioning, performing good leak tests together with you. Reducing intravenous fluid, why? Because otherwise you might have edema and the stapling quality might be less. Reducing the opioid as much as possible, even you should start learning opioid-free anesthesia, at least for patients with extreme OSAs and respiratory problems. Ask that he also follows some kind of lung protective ventilation guidelines, certainly at the moment of the extubation, so to keep the lungs open and to prevent having atelectasis in the recovery room, so avoiding also the requirement of giving oxygen. And you should work that out as a team, working together on that. The B-chair position is that important, so that I put an extra slide on that. Preoperative, the patient should never be laying flat, otherwise he has to look to the ceiling, it's less comfortable. Intubation for us is easier if the patient is in the B-chair position, at least 20 degrees. And we are gaining one safe apnea time, so one minute. But obese patient has a very short safe apnea time. That's why we choose for the European Society, the B-chair was the lower in the time. Intraoperative, during the procedure, during pneumoperitoneum, you will get one extra little workspace if you have the B-chair position, and that at least 30 degrees, and the legs laying horizontal. So the reverse Trendelenburg is not that ideal. It also makes ventilation easier. We have lower pressures in the lungs to ventilate. And postoperative, again, very important for during the extubation to be able the patient to breathe more easier, and it's very more comfortable for the patient to stay on that. The explanation of the safe apnea time increase you can find here. A normal patient, we have roughly 8 minutes before we really need to start ventilating, and patient will be desaturating. In children, this might be 4 minutes, 5 minutes only. In obese patients, severely obese patients, this is sometimes only 2 minutes. And if you put the patient instead of flat or instead of the reversed or the B-chair position, here that makes no difference, you will gain 1 minute safe apnea. It's not that much, but it's helping there. So never have the patient laying flat like that during the induction phase, but the B-chair position here, the patient is already intubated. The leg flexion is an old study with it showing that in the reverse Trendelenburg, compared to the B-chair, we gain more than half a liter workspace at the same pressure. So you will get more workspace in the abdomen, or you can work at the lower intra-abdominal pressure and have less ischemia of the peritoneum. It facilitates the ventilation of the lungs during pneumoperitoneum. This study is showing this nice result. Blue line is when the patient is without pneumoperitoneum. With a pneumoperitoneum, you see the compliance of the lungs decreasing, the red line. Then if you put the patient in the B-chair, we're coming back, not to the original value. You still have a compliance a little bit less in the lungs, but it's improving. If you add then the PEEP, the green line, you will see that the volumes are comparable back to what it would be without pneumoperitoneum. So laparoscopy, 2 points, always B-chair to facilitate ventilation together with an increase in PEEP. 5 centimeters for everyone, 10 centimeters for obese patients, 10 centimeters for non-obese and pneumoperitoneum, obese and pneumoperitoneum, 10 to 15 centimeters of PEEP levels. B-chair, so you see the patient is not laying fully flat, 10, 20 degrees, induction 20 degrees, intubation also 20, 30 degrees, during the surgery 30 degrees B-chair, in the recovery one extubated even 45, almost sitting right up or sitting right on the bed, that's a 90 degree sitting up. So that's important. The B-chair the value is increasing till the end, till the exacerbated phase. Even later on in the recovery of on the ward, still have the patient in some kind of B chair. Too much anesthetics, well, that's not helpful. Too much hypnotics, well, you can avoid that by measuring the depth of hypnosis. Too much opioids, well, there's no need for that, but we measure the sympathetic tonus. By that, you can reduce the amount of opioids. You can also go to the opioid-free and verify if monitoring is sufficient. Too much muscle relaxants, well, that's one of the only groups of drugs. There is no risk for toxic dose, no risk for possible side effects, only if the patient is full reversed after the procedure and monitored to be full reversed. And then you can safely give a very high dose of neuromuscular blockers. So don't give high dose of hypnotics, don't give high dose of opioids. You have your patient laying calm and not moving. Use muscle relaxants for that. There's no side effect in the high doses compared to hypnotics and opioids, only if full reversed and verified. And here, this is a patient where the hypnosis is really too deep. You see burst suppression. The BIS is at 34, is at the low end, and this is too low. The burst suppression shouldn't be happening. This patient might have more cognitive dysfunction post-operative. Again here, so you need to try and to get the blood pressure down. You shouldn't do that with hypnotics. 1.5 max sevoflurane, the blood pressure was too high. Well, don't do that with hypnotics. Do that with directly working drugs on the blood pressure. And maybe in the past, we have been using one dose fitting everyone. Today, we are trying to do personalized prediction models based on age, weight, sex, genetics. However, the future really will be to measure the effect in each person and adapt till the effect is reached. So just enough to do the job. And it's time for a personalized anesthesia, monitor each patient beat to beat, depth of hypnosis, muscle relaxation, and depth of sympathetic impression. Well, shortly. The next point that is quite important is the fact that the stomach is frequently filled with air, risking some trauma on the moment of the start insufflation of the abdomen. Mask ventilation is frequently difficult in the morbid obese patients. Some air is insufflated in the stomach, even at a low pressure. If not suctioned out after intubation, you might have a traumatic varus needle insertion, and you will have abdominal workspace. The air might be moving deeper into the duodenum, jejunum, impossible to get it out after some time. Nitrous oxide, if used, will diffuse inside and make distension. So never use nitrous oxide in these cases because it even gets worse. And the solution is reduce and avoid mask ventilation, but always suction after intubation, even without using a mask ventilation, like in rapid sequence induction. Little bit CPAP at induction helps. High nasal flow is another approach. No mask is needed. Apneic oxygen diffusion can help. However, still the patient might be breathing deep in and out and aspirating a little of air in the stomach. Always aspirate is the only way to get it out. This is an example of a patient where there's too much air in the stomach. If you get that out quite early, then it will help and facilitate. If you wait too long, this air will be moving out to the jejunum, and this is a disaster because you will never able to get that anymore out. Give enough deep neuromuscular block and measure the depth is quite important because you cannot predict what dose you need. You cannot predict how long it will work. And you can predict full reversal. It's not because it's 1 hour ago that the patient will breathe very well. So you have to monitor neuromuscular block in the periphery on the thumb, but you are working on the central muscles. The problem is the spontaneous reversal might start 10 minutes early in the abdominal muscles, and we are not aware of that as an anesthesiologist. So what we do is we dose till we get deep enough neuromuscular block on the thumb. We give a continuous infusion, and we monitor and stay with a post-tetanic count around 3 or 4. And we measure also to be above 90% at the moment of extubation. Many of us are giving bolus of rocuronium, but then we are always too late, and we then only give it when the surgeon is asking it. We see the difference in the sensitivity. these very sensitivity at the thumb, so it's easy to relax the thumb, it's harder to relax the abdominal muscles and the diaphragm. And there is a 10 minutes earlier reversal in the abdominal central muscles compared to the thumb. So even if you are measuring and staying deep with working with boluses, we might be 10 minutes too late, and you will be the first seeing the patient who's not relaxed anymore. We look to the monitor and say, no, he's very deep. Yes, but in 10 minutes, we will see that you are right. So this is a problem of difference in sensitivity and difference in time spontaneous reversal making that. Just here as an example, as you can see here, and I will show you that one, measuring on the thin thumb and measuring more central on the upper arm, we see a difference. We have here already a thinner fall of 2 in the central muscles, while it's still 0 on the peripheral muscles. Large variability for patient. The patient, so on one patient, the deep block can stay there for 10 minutes with the same dose, while another it stay there for 2 hours. That's we have to measure, otherwise we are not sure we are deep in every patient. Another very important preparation aspect is weight reduction, and in 2 weeks' time we can get like 10% reduction in total body weight, but we'll get 5%, 10% in liver, in the visceral fat, up to 25% of liver fat reduction. And so it really helps do that. There are many factors that have an impact on the workspace. I will not go in detail on that. Having been had on laparoscopy in the past might help too. Deep neuromuscular block, for women, many children in the past helps also. Opioids and deep anesthesia do not help in increasing the workspace. Only deep neuromuscular block is helping there. You can find the lowest intra-abdominal pressure easily by setting the insufflator on 12 for the non-obese, on 15 for the obese patients. You start insufflating first with the volume measured on 0, and look when you reach 3 liters. Stop the insufflator and look what pressure you need to have that 3 liters. If this is less than 15, stay at that pressure and you can work at a lower pressure. Sometimes even 15 is not enough, and you will have to go even to 20 to have at least a minimum of 3 liters being the minimum volume to work and do upper abdominal laparoscopy like for bariatric. Access to the diaphragm, repair of an herniation, you might ask to go a little bit higher to have access, to then come back down. If you would have an open access and a hernia, be aware that you have to work at the lowest intra-abdominal pressure possible, otherwise air may go out in the thorax and creating pneumothorax. And then we need very high PEEP levels to keep the lungs open, because we are working in centimeters of water PEEP. You're working in millimeters of mercury in the abdomen, so that's 1.3 difference per percent. So we have to go 30% higher in pressure on the PEEP to be on the same level. We lower the blood pressure during the stapling and increase at the end. Higher blood pressure thickens the peritoneal mucosa, induces hematomas in the wall while you are stapling, and you might have bad surgical vision of your anastomosis. So we keep the systolic blood pressure below 100 during the stapling. Here you can see on the left, it was not done. The blood pressure was around 180, quite high at the moment of stapling. Now the blood pressure is 100, but already you have a hematoma in the wall. You say, I'm going to use a reinforcement, but that's not really helping to avoid at a higher breath pressure. Even with reinforcement, you will have more bleeding. The staple will always bleed when the blood pressure is rising. It is white when the blood pressure is low. Oozing is not a problem. It's a problem when you have active red blood coming out, or there is a real spray. That, if you miss that, you will have a problem. That's why we increase the blood pressure at the end above 140 to find these active bleedings or these sprays, to put an extra clip on that, and by doing so, we can avoid having a reintervention for bleeding or stop that. We also have to look intraluminal. For that, we do an aspiration through the gastric tube, verifying if it's all dark blood, no problem. If it's red, we have to call the gastroenterologist to put the clip on the inside and to handle that. Leak test, I'm not going in detail, but you have to inject quite fast, and you will air and water, and you will see some air bubbles coming out. You have to do suture and to repeat the leak test. We reduce the fluids intraoperative. All the fluids are normally going out. We measure pulse pressure variation. I will show you here. That's an example. This patient is hypovolemic. You see the pulse pressure coming down and up again. That's the only way when we are going to give extra fluid. Otherwise, we keep the patient at a very low filling rate. Nice study showing that if we give too much free fluids, you will have the second day lower saturations in your patients, not on the first day or in the recovery room immediately, due to the edema that is happening there also. Reduce the opioids intraoperative. There's no need for analgesia intraoperative, but it's need to reduce all this stress. Opioids have a lot of problems. Opioids induce postoperative respiratory depression. This is more frequent in patients with OSAS, cardiopulmonary disease, and in the patients getting indeed a high dose of opioids. No impact of obesity itself, a channel of ASA classification. Two examples, the patient breathing obstructive. It might be also that the patient stops breathing by short moments. So two problems of respiratory depression happening due to the opioid. So the opioid gives respiratory rest, but already give also obstructive breathing. And that's an extra problem we should be avoiding. Opioids also inducing vomiting. This is dramatically very frequent in bariatric procedures. It's really related to the dose of opioids. If you can halve the dose of the morphines of opioids used intraoperatively, you will get 20% less PONV, 10% less vomiting. Why important? Well, vomiting is a disaster after bariatric procedure, sleeve and gastric bypass, because the last staple line might herniate through the diaphragm on the moment of a vomiting reaction. And so even if leak test and everything was perfect, correct, thereafter the patient starts severely vomiting, and you have now a high pressure over the staple and more than 100, 200 millimeters of mercury, even on the moment of vomiting, and no staple line, even reinforced or oversealed, is strong enough to sustain that. So vomiting should never happen after bariatric procedure. We keep the lungs open by the lung protective ventilation guidelines, and on that I will focus on the aspect of immersions, that is never suction and inflated tube, full reversal, no opioids, low oxygen fraction, and estimating in the B chair position under CPAP, very, very important. Applying all these principles of ERAS in bariatrics, and on top of that, lung protective ventilation, opioid-free anesthesia, peritoneal protection by steroids and lower intra-abdominal pressure, and monitoring anesthesia in the correct way, we really can improve the outcome next to your surgical skills, and very important to have the perfect quality. We have been looking to a large group in our database in the last 8,000 patients, finding out that giving continuous deep neuromuscular and opioid-free anesthesia was reducing by 50% the amount of minor and severe complications. And that is something we really could find here also, that anesthesia, surgical experience, a younger age, opioid-free anesthesia, deep neuromuscular block, and was really associated with less complications. And some of them also with shorter stay, less ICU need, less readmission or operation. We have to speak with each other to be a real team to make this possible. And by that, I will conclude with the 10 key points you should remember, and you discuss with your anesthesiologist to handle that once in a month, to add a new key point in improving the outcome for your bariatric procedure. I'm just adding here, very shortly, you can take a photo of that, the key points for every step in anesthesia, and these the key points for pre-anesthesia planning, the key points for anesthesia induction, the key points for anesthesia maintenance, anesthesia emergence, and the anesthesia care post-operative or post-anesthesia. Thank you. With that, I would like to stop, and there might be certainly some questions.
Thank you very much for this excellent presentation. Definitely reinforces the idea of working as a team in theaters and the importance of the experience, both the anesthetic and the surgical team, and effective communication before, during, and after the surgery for better results. It's really amazing. Thank you very much. I don't know if we have any questions from the panel.
Good morning, everybody. Excellent presentation, and it is good to hear that there is much more better organization with the bariatric surgery anesthetist making progress. And one of the innovations they have been doing is total intravenous anesthesia. Is there anybody who can comment on that?
Do we have the benefit of having Dr. Mulier with us, or was a recorded presentation?
No, he's not able to make it, George. He has sent his apology this morning. He got stuck in emergency.
Yeah, for me, it was a really, really fascinating presentation. And this is all things that we all experience day in and day out in theaters. And that makes me wonder, I don't know what is the status in your hospital. Do you always have an anesthetist with you that is specialized in bariatric anesthesia, or most of the time, or occasionally? And how important this is it?
Luckily, we have a very good team of bariatric anesthetists, and they're also training more senior trainees into bariatric anesthesia. So we do rely purely on bariatric anesthetists to manage the bariatric surgery.
Yeah, I have personally witnessed, difficulties in theaters when you have someone who is not really dedicated for whatever reason, last minute replacement, etc. And you can feel that, things can go the wrong way very easily. We have witnessed also instances with stapling of the tubes or insufflation of the tubes of the esophagus and disasters. So I think communicating with the anesthetic system is really paramount. Also, relaxation of the patient, especially in challenges patients with high BMI, extra space. It is really, really important to deliver safe operating. And I think the presentation gave us a very good insight on how we can achieve that.
Definitely. I think we can think about concluding this session, Sanjay.
Yeah, that's a good idea. As we are just about in time, what we will do, thank you. Yes, thank you, George, for joining us. Highly appreciated. What we would do, we'll conclude this session. We'll just have a minute break for the back-end team to move to the joint session, because the next session is a tuck session, which everybody, including doctors and the allied health professionals, will join together. So we'll give us a half a minute to a minute break, and then we'll pull back again. Thank you, team.
Thank you very much for the excellent congress. Thank you.
Thank you.